sweating, they will start to sweat profusely, some individuals. And cyanosis, thank you. And cyanosis, yes.
What is the relation between seizures and heart attacks?
I don't know if there is a relation unless they're happening at the same time. A seizure is more so with the brain activity. There's a shut off with the neurological response. A heart attack is a shut off with the vascular flow.
Can it do anything?
Now, can it happen at the same? It's a possibility it can happen at the same time. Or say, can a person have a seizure and then a heart attack? It is a possibility, but it's two different pathogenesis.
Okay, I have a friend, a boyfriend, just a few days ago passed away. He had a seizure and it caused a heart attack, but they don't know why.
Okay.
He passed away from it.
Yeah, so what happens if the neurological system shuts down, can it now lead into other organ? Yes, so that makes sense. But the seizure would have to happen first, then the heart attack, but not the other way around. But it is two separate things though. It's two separate things. They don't really, it's not like it'll happen together. Okay, so let me get back to this. Now, just really quickly, as far as treatment for an angina, what do you think, just going over the pathogenesis that we know, what do you think you would do to treat an angina? What would you want to do to the vessel? Dilate it, very good. You will want to dilate the vessel. So understand that any type of vasodilator type medications, anything that's going to vasodilate the vessel, such as nitroglycerin, calcium channel blockers, they also relax the vessel to dilate and open up. They have some others. So not to go through a whole bunch of medications, but just to give you an idea, the way they treat this is to open up that vessel, okay, as quickly as they can to try to get blood flow to the myocardium to stop that feeling, or to stop that symptom. Okay. And that's that. Now, acute coronary syndrome, we're going to go into this in more detail, and so yes, we already discussed the type of chest pain. So just to focus here, an unstable angina is going to be a partial occlusion, whereas an MI means that that patient has a complete occlusion, okay, where there's no blood flow getting through whatsoever. There are ways to diagnose this, and we're going to use ECG and biomarkers to show you how to diagnose this. Okay. So this is the presentation. Presentation here. I like this chart a lot, and I will say this. Please make sure you guys know this chart for test purposes, but understand, you know, the information behind it. So it's not that you have to memorize the way it's laid out, but just understand the information behind it. This gives you a full kind of workup, okay, of what could be going on. So they give you presentation, organ diagnosis, ECG, cardiac biomarkers, and final diagnosis. So we're going to take each one. In this we're going to explain the two different types of MIs, okay, that can occur. So let's say signs and symptoms of cardiac ischemia. So obviously this patient's having an unstable angina, okay, among some other things maybe. Now, before we jump to heart attack, we want to just put that person in a category as an acute coronary syndrome, okay, and then until you get the other tests done. So the first test that they have listed here is an ECG. So we know that an ECG is for what? What is the ECG used for? Okay, very good. For the electrical conductivity of the heart. And an ECG, for the electrical conductivity of the heart, not only is it the electrical conductivity of the heart, but keep in mind that this also gives us a snapshot of the cardiac cycle. Okay, so if you remember from physiology, the P, QRST, all of those different areas tell us exactly what's going on in the heart, so they do correlate. So it tells us when the heart's relaxing, when it's contracting, okay, when it's filling, And I believe they even had a chart to show you how each segment correlated with the different components, okay? So, the whole point of that is saying this. They have here ST elevation, that is an abnormality. Okay, so let's go over normally what the ST segment is for. Normally, at the end of an ST segment, the heart should be relaxing. And it should be relaxing and getting ready to fill for the next cycle. Okay, so that's normal. Normal process of a ST segment, the heart should be relaxing at that moment and getting ready to fill for the next cycle, or the next round of this. Okay. Now, the problem here, this ST segment is elevated, which means that the heart is not relaxing. It's still contracting, okay, or still in a contracted state. Why? Possibly due to damage. Okay, so this is telling us that, and this is a type of MI, and I'll go into that in a second, but this is telling us that this person that's having an MI is showing on an ECG that ST elevation is showing us that they're having actually more damage, okay, to the heart, to the point that it's throwing off the cycle. Okay. Now, the next thing they have here is cardiac biomarkers. So, let's say, for example, patient has an infarction. Patient has the infarction and they're breaking down the muscle tissue. Muscle tissue breaks down. What makes up muscle fibers? And I'm doing this for a reason. Very good. Actin, myosin, the components on the sarcomere, thin filaments, thick filaments, okay? All the different bands and zones. I know you want to remember that. However, the whole point of this is that when those fibers break down, keep in mind that portion of the muscle is dead. If it's dead, it's going to break down. When it breaks down, it actually will release the components of that tissue. So it actually will release the enzymes that are made up in the muscle fibers, and they go into the bloodstream. So two main things that they look for is creatine kinase and troponin. More so troponin, but creatine kinase is also part of muscle, okay, the makeup of muscle. Creatine kinase and troponin. So to make it easier, if you can look at your clinical reference guide at the top of page 489. At the top of page 489, you have cardiac markers. So for cardiac markers, you see they have creatine kinase, and then they have creatine kinase MB, that's for the M band on the sarcomere, and troponin 1. So just highlight those and memorize those values, and I will include that on next week's test as well. Those are values that are needed to test to tell us that a patient's having an MI. I will say this is the most definitive test to let you know that a patient's having a heart attack. Because if you have that blood work done, that's telling us that that muscle tissue is dead, and all of the components of it, those enzymes are released into the bloodstream, and that's how you know that muscle tissue died. Okay? The ECG does not really tell you that the person had an MI, it's just telling you how much damage occurred to the heart. But it's not a definitive test for an MI. So, to say that the type of MI that happens here, this is called an STEMI. So ST for the ST segment, E for elevation, MI, myocardial infarction. Sometimes people call it STEMI or whatever. So STEMI. ST for the ST segment, E for elevation, MI for myocardial infarction. So that's that type of MI. Now, say for example, you have a person that has an ECG done. ECG looks good, not a problem. They have blood work done, no presence of biomarkers or elevation of it, everything looks great, but they're still having an unstable angina. What's wrong with this person? They're not having a heart attack because they don't have presence of markers in their bloodstream. So what are they still having? Or what are they?
Chest pain.
They're still having chest pain, but why? It is an ischemia, but what's causing the ischemia? Very good, the plaque. So this person is having a really complicated plaque, basically. So they have a really complicated atherosclerotic plaque, so big, so much to the point that it's giving them an unstable angina. But not enough to give them a heart attack. Okay, so they're still just having a big, unstable atherosclerotic plaque. Okay. Then over here, ECG is done, everything looks good. Check the blood work. They do have a presence of biomarkers. And so in this situation, this person is having a heart attack. And so this person is having a non-ST elevated MI. Okay, so a non-ST elevated MI. From my understanding clinically, this one is worse than this one because the STEMI, it shows obviously more damage to the heart muscle, whereas this one does not. I mean, they're both a heart attack, but this one is worse than the other one. Okay. So, I already drew my picture about that. Okay. Now, this diagram goes over, and I'll just give you the information behind this. When a person has a heart attack, those cardiac markers, they stay in the bloodstream for 48 to 72 hours, even after a heart attack. They stay in the bloodstream for up to 48 to 72 hours after a heart attack, which is a good thing because we have all heard of stories. Sometimes patients, they have chest pain and they don't go in right away, and then when they finally go in, you say, oh, you had a heart attack. You say, oh, really? I didn't know. Okay. And so sometimes it can happen when people do have what they call mild heart attacks or whatever. And so the good thing is, if these markers stay in the bloodstream for that period of time, at least you know how much damage was done to that part. Okay, so that's a good thing that it stays that long. Okay. Now, this next slide goes over what is considered to be compensation, okay, of the heart. And I do need you to know this, and know this like forever and ever. And the reason why is because we're even going to go over this again with shock. When you hear the term shock, shock is considered a cardiovascular disorder, okay? And so we'll continue that on the next time we meet. Okay, so when a person has an MI, and they have here MI, but let's just say any cardiovascular issue, they will have a decrease in cardiac output. So when there's a decrease in cardiac output, meaning that there's not enough blood leaving the heart as it's supposed to, what's going to happen is the body will sense that. And once the nervous system senses that there's a drop in cardiac output, sympathetic nervous system will get activated. Excuse me. Sympathetic nervous system will get activated. Once the sympathetic nervous system gets activated, that will actually cause the heart to try to contract, okay, increase the heart rate, and increase the blood pressure. Okay, not increase it in a bad way, but increase it to get it back to normal. Okay. And so it will do all this to try to increase and bring proper circulation. Okay. This diagram, for those of you who like flow charts, you can use this, okay, if you like. This kind of goes over what we discussed already, so partial occlusion and then total occlusion. And so it just kind of breaks down everything for you. You can use that at home, but I won't have like direct questions from it, but if you need to just see the full breakdown, you can use it. This particular flow chart you don't really need, you can cross this one out. Okay, let me go over this and then we're going to take a break. Sudden cardiac death. What happens if a person dies unexpectedly after they start to have these like type of angina type symptoms? This can happen, and so let me give you the causes that can allow this situation to occur. One cause is multivessel atherosclerosis. multivessel atherosclerosis. And that makes sense because if a person has atherosclerosis in a number of vessels, that's not good, okay, for circulation. Multivessel atherosclerosis. Another one is myocardial atrophy. Myocardial atrophy. Which means if the heart is small, overall, is that a good thing? No. Because what's going to happen, the heart is not going to be able to function as it's supposed to. Okay, kick out the amount of blood it needs to. And then the very next thing, too, we have is fibrosis and scarring of an old MI. Fibrosis and scarring of an old MI. Fibrosis and scarring of an old MI. So what does that mean? When a person has a myocardial infarction, so say it happened here, that means that that tissue in that area is now fibrotic, as we talked about earlier, which means that it's stiff. And is it going to contract like it normally would? No. So now let's add to it. Let's say, and we have heard of this situation, people having multiple heart attacks. Let's say if they had a heart attack here, another one here, another one here. That means that all those areas of the tissue are really now going to be compromised. So is that person going to have now really good contraction? No. So this can unfortunately possibly lead them into cardiac death, okay, early renal death. And then the very last one, electrolyte imbalance. Electrolyte imbalance. And I'm quite sure we have also heard of this type of situation where a person's electrolytes are imbalanced, okay, or not enough. And why is this important? Because we know we need electrolytes or we need ions for muscle contraction. So if a person does not have enough potassium, if they do not have enough calcium, okay, sodium, so forth, to make that muscle contraction occur, the heart is definitely one of those things that can be affected. And you don't want to play around with that because keep in mind the heart continuously beats, okay, continuously contracts. It doesn't take a break. It's not like skeletal muscle. So we need adequate amount of ions for it. Okay. All right, let's take a break. I need to get myself together because I feel so much pressure right here. And I know I look weird talking to you, but